Welcome to the Beverly Hills Plastic Surgery Podcast. I am Dr. J. Calvert, and with me today is Dr. Millicent Rovelo, one of the top blepharoplasty surgeons in Beverly Hills.
Well, I accept that. Thank you. Which, by the way, that's what we're talking about. We're talking about blepharoplasty, but specific lower blepharoplasties. And the reason I'm laughing is because this is a ridiculously hard, underestimated surgery that people spend years perfecting on how to do.
It's really hard.
This is not just your mom's upper blepharoplasty.
No, and by the way, anybody who says I'm totally awesome at this has no clue how hard it really is.
It's so hard, and it can come back to bite you in so many ways. So that's why I scoff at that designation.
You are actually really good at it because you understand how hard it is.
Yes, that's true.
And you do a really nice lower lid blepharoplasty, and I think we both do. There are lots of ways to do it.
Let's define what we're talking about here. These are really big words. So a blepharoplasty is just fancy doctor word for an eyelid surgery. You can have upper blepharoplasties, which addresses the extra skin or fullness or heaviness of the upper eyelids. And then you can have lower blepharoplasty, which, shocker, addresses the lower eyelids. So what we are talking about today specifically are the lower eyelid surgeries.
Right, because the upper lids, just to kind of, for completeness, we'll say, typically the upper lids are a skin excision of some kind and some sort of fat manipulation. There's so many different variations on that theme, but really...
It's pretty straightforward,
and the problems are addressable should they come up, and they rarely do come up if you're really smart about how you design your upper lid blepharoplasty.
Yeah, that's an incision that's just in a natural skin crease in your upper eyelid. You may or may not need to remove a little bit of fat that sits below the muscle, and then you close it up and you go about your day, and your eyes look brighter and shinier, and it's kind of a win. Refer back to some of our blepharoplasty podcasts for that. But the lowers, they're a little more complex than that.
Yeah, and so there are lots of ways to do lower lid blepharoplasty. The traditional way that I was reared on as a young plastic surgery resident was the skin muscle flap, which is a subciliary incision.
That's an incision.
Which goes below the lashes.
Right below the eyelashes. Right below the eyelashes.
Yeah. And I'll talk about something I've seen recently, which bothers me and is disturbing, but we'll get around to that in a bit. But so that's the old school way. You make a skin muscle flap. It was really effective. The downside was you saw a lot of scleral show. You didn't necessarily get ectropion. Ectropion is when the lower eyelid pulls away from the globe and you can see the conjunctiva. Right.
Scars in a lower position.
Scars into a bad position. Scleral show, which is where you see the sclera is the white of the eye, and the lid pulls away just enough that there's more space below the limbus of your pupil that you see more white under the pupil than the colored part of the eye than you should. And it's
well, it looks a little strange because so we're talking about the iris here. So the iris is the colored part of the eye. And in a, quote, normal eye, although there are variations in anatomy and certainly across different ethnicities, but in a Caucasian eye, usually the lower lid sits right up against the bottom of the iris.
The colored part
pupil,
of the eye. And I call it the pupil because people don't know iris necessarily.
But the iris
is the corona colored part around the pupil.
Around the pupil. And when the lower lid sits right up against the bottom of it, you don't see any white between the bottom of the iris and the lower lid. Scleral show means that you have the bottom of the iris, a rim of white, the white part of the eye, and then your lower lid. And that is actually normal anatomy for some people.
For some.
But if you didn't have it before surgery, you don't really want to have it after. And so that is what's called scleral show, which is different than, like you said, ectropion. Ectropion is when you have scleral show, but the lower lid is actually scarred down into that position, and it's really hard to manipulate it back up into proper position.
Yeah, and I'll tell you that if you looked back at those old skin muscle flaps, a lot of them had scleral show.
A lot of them have it because you're going from the skin directly down to the orbit and the eyeball, and you're going through all the layers of the lower lid, and as things do when they heal, they scar. And so when they scar, they pull down, and that's where you get that shortening of the lid.
And in my residency, I discovered the transconjunctival approach to lower lid blepharoplasty, and it changed the game for me, which I love.
It changed the game for many, many people. Transconjunctival, so the conjunctiva is the lining of the inside of the eye. So if you pull your upper eyelid up or your lower eyelid away from your eye, you'll see kind of this fleshy, kind of glistening lining on the inside of your eyelid, right up against the eyeball. That's the conjunctiva. And so going through the conjunctiva is much less likely to cause all that scarring that going through the skin did.
Yeah, and there are a couple ways to approach it. There's a very simple way to do a lower lid blepharoplasty transconjunctivally, where you put a retractor into the lower lid, you pull it away, and you go to the lowest part, what's called the fornix. That's the end of the conjunctiva where it bends around and comes up onto the globe, actually.
Basically where it meets the lower lid bone, the orbital bone.
And you literally just retract it and open the conjunctiva, and your fat kind of spills out to you, and you trim a little bit of away, and you reduce the amount of fat in the lower lid, and you're done. And you never cross through any of the crucial structures that cause the ectropions and scarrings and problems.
Except, and some of these stories, I think what we're going to say today is hopefully applicable to patients, but also I think for residents and people in training, there's some really important things that we are going to mention here. One of them, with this technique, I heard a story about residents that were doing this technique where you put the retractor inside of the eye, pull it down towards the bone, and then just bovie straight onto it, hoping that you'll hit the septum and the intraorbital contents. Instead of going in the right vector with the bovie down towards the bone and the fornix, they went through the conjunctiva, through the muscle, through the skin, and came out the other side. So now they have a 3-layer opening and incision. And that was a major problem.
Just awful.
We might call it the easier technique and the easier way of getting access to this area, but you still have to be really mindful of where you're working, because even though that may seem like a small little problem, it's tiny, right? It's like 0.5 centimeter incision. The problem it causes with scarring and ectropion are huge. So be very mindful of where your vectors are and what exactly you're going all the way through to get to where you need to be.
Yeah, and that technique, though, is very safe and pretty straightforward if you know how to do it.
If you're going in the right direction.
Sounds like somebody needs to get a refresher course.
Yes, but yes, you're correct. That is a very straightforward way, typically, of getting to where you need to be through a transconjunctival approach.
By the way, all the Gen Xers in the audience right now just heard me say refresher course, and they recognize that is a Fletch reference from the 80s movie.
No, okay.
Fletch. Come on, guys. It's all ball bearings these days. Maybe you need a refresher course. So anyway, back to our transconjunctival. The last way that I want to talk about is the way that we like to do it, which is a very controlled. I don't know why I do this, but I love it. It's such a very safe technique, and it's so clear about where you're going. And I love that you don't disturb the septum orbitale. It's like really great because if you don't disturb it, you're not going to have problems. And lo and behold, I haven't had problems with this technique if it's done properly. Basically, we put in some stay sutures into the lid and into the conjunctiva, and then we approach the preseptal region, which is in front of all the orbital fat, the stuff that we're going to reduce. Mm-hmm. And we travel down, we open the conjunctiva, and we travel down and behind the orbicularis muscle in front of the septum orbitale, and the fat is right behind it, hiding, waiting for us to get to the bone of the orbit, the infraorbital rim. And then once you get to the rim, I make a little periosteal pocket that opens up a space where the tear trough is. And then you can open the septum orbitale down low where there's no issues with retraction and problems with scarring. And then you can remove whatever fat you want. You can reposition the fat. You can bovie the fat. You can do whatever you want. You can see the inferior oblique muscle. You can do whatever manipulations you want. And I always say just be sure you get that lateral fat pad, because oftentimes it's hard to see the lateral fat pad of the lower lid. So this technique, which I've been doing since I was a resident, people either love it or they absolutely hate it.
I love it. This is a technique I use. I love it. As you know, you've operated with me a few times. I really like to see my precise anatomy. I don't like sort of just approximating where things are. I like my clean planes. I like to know my anatomy, like what's above me, what's below me, where am I in space, where are the important structures. And this is just such a clean way of doing it and being able to visualize all of your planes and your anatomic structures where they are undisturbed. And so I do it pretty much almost exactly the same way. Once you get to where you're going, then you can do all the work that you need to do with the fat.
It's so safe and so controlled. And, like I said, with the fellows and the residents, they either go, oh my God, this is awesome. Or they're like, this is such a ton of work. Like, how is
it? It is hard.
Like, why not just pull the thing open with a Damar and crack open the conjunctiva and be done with it?
It takes a little more work, but it's so much more elegant. And I like it. I like knowing what I'm doing. I like knowing exactly where I'm going. Yes, it takes a little bit more work to do that dissection, but I think it's worth it.
If you're trying to get rid of your lower lid concealer, you need to do this with the mid-face lift, and Bob's your uncle.
Let's talk about that, because what are the reasons that people get a lower lid blepharoplasty? So we sort of went through the technical ways of how to do it, but why would someone do that? And there are many different reasons that people come in saying, I need to get my eyes done. And yes.
Right here.
I know.
I'm next.
I'm looking right at you.
Thank you. You see these things? They're ready. They're ripe for the picking. Yeah, they're like apples on the tree.
I see them.
Pick me, please. They're ready.
They're ready. And sometimes this happens. Sometimes this is very genetic. Sometimes you'll get a young patient who comes in and they're in their 20s and they're like, I have these puffy eyelids that have been there since forever. And that's just a genetic thing. The puffiness that you see across any age spectrum is intraorbital fat. So there is fat that lives around your eyeball and is tucked behind what's called a septum, which is sort of like the covering around the eyeball. And in some people, for genetic reasons, that lower fat bulges out more than in others. And so what they see as bags are really just some intraorbital fat coming through. Now, some people also just have swelling, bad swelling and edema under their lower eyelids. These are people, and that's where you have to get a history. So if they come in, they say, the swelling is worse when I have allergies. It's worse when I wake up in the morning. You're looking at more of an allergy thing, and they may or may not be someone that needs a blepharoplasty. So you got to sort of tease out what's causing their under eye swelling. Because if you go into a blepharoplasty on these patients, you may actually make their swelling worse because now you've blocked some of their drainage channels. So you have to do a good exam and figure out what is causing that swelling or poofiness under the lower eyelids. As you age, it definitely tends to be just that extra fat herniating through. So it creates bags under the eyes, and it also accentuates that tear trough deformity. The tear trough being the hollowing under those bags that get more pronounced the bigger the bags get.
Absolutely. And then when you do it with that mid-face lift, it really tightens.
I know you really want to get to the mid-face.
I know.
Let's okay. We're going to focus on the lower eyes just a little bit longer.
I know, but it's so important.
I know, it's so good. We're going to get to it.
Okay. I'll back it up.
Back it up.
I'm going to reel it in.
Yeah.
Okay,
Stay tuned.
I'm here.
It's coming. A lower lid blepharoplasty on its own means that you remove the extra fat. If there's extra fat that's herniating and causing those bags, you can remove it.
Get it out of the way so you can do the mid-face lift. Oh, sorry.
I'm going to smack you. I'm actually going to reach across this table.
I had to do it because I could kind of see a little bit of smoke coming out of your ears at that point. And I was like, yeah, I got to do that. Sorry. Okay, keep going.
Carry on. Gosh darn it.
And do the mid-face. And then pull up the mid-face. Sorry. What?
Listeners, do you see what I have to deal with?
It's hard.
It's really hard.
I know, it's hard. And you've hung in there. And I want to give you credit because not many people would have done what you've done. And there should be an award for you, but
thank you.
I don't know if there's a PODD or something like that. A PODDY, not a POTTY. That's different. But maybe there's a PODDY award that could come out for you for being the one who takes one for the team.
Yes.
Okay, back to the lids.
Moving on. The fat that's herniating. You remove it. or you redistribute it. Redrape it. So that little pocket that you're talking about, creating a little pocket underneath the rim of the eyelid where you see the hollowing, where you have that tear trough. If you take the fat that's from a place where there's too much of it, you can put it into that area where there's too little of it, and you can blend that hollowing, that grooving, that tear trough darkening in the circles that people don't like. And that's an excellent way of addressing those problems. The fat herniation, i.e. the bags, and that tear trough, that groove, both of those things can be very easily fixed, addressed with the lower lid blepharoplasty.
And I used to do transcutaneous sutures on those fat pads. I used to put a stitch through the fat, and you haven't ever seen me do that because I abandoned it. You can do it. It's okay to do. You can tie a little plain gut or something like that onto the fat and bring it through the skin and like put a little piece of steri strip or something on there to hold it in place and really direct the fat into that tear trough.
Where you want it to sit.
It works. I learned that from Henry Kawamoto, believe it or not. That was the guy who was talking about that back in the Dizay. But I did have like a little bit of like lumpiness and scarring with it on a few patients that I was like, maybe the stitch is killing the fat a little too much and causing some fat necrosis. It kind of resolved and went away, but I wasn't crazy about it. So that's why when I make that pre-periosteal pocket, I just let the fat sort of spill into it. And by the way, that's worked.
Yeah,
it's been fine.
That works.
What do you do? Do you do a spill?
I do the exact same thing. I let it spill over. I don't try to put it in place or anything like that.
I don't think you need to. Where else is it going to go?
Yeah, exactly.
If you've made the pocket.
And you've opened the septum, like it's going to spill out
where it's gonna
and
go.
it's going to sit. So it does tend to do the job. So that's that. All right, Dr. Calvert. Is there anything else that we could possibly do at the same time as a lower blepharoplasty to enhance our results?
Well, there is this one thing that I like to do every now and again.
What would that be?
That would be the endoscopic mid-face lift.
Shocking.
Now, it doesn't have to be endoscopic either, though. You can also do it through a canthotomy incision, which I do every now and again in a blue moon when they don't need a brow lift or a big cheek lift. It's just to get that sling of the orbicularis oculi muscle to come up. You can do a canthotomy, which is you open the lateral canthus and you can elevate it. And the secret, for those of you who are following along at home, is to cut through the orbicularis oculi muscle, undermine subperiosteally up to the temporalis fascia, and do a little orbicularis sling. And you can do a really nice mid-face cheek lift through the lid that way. It's not as dramatic as when you do an endo, but it does the job. If you're really talking about
isolated,
this is the issue here, just the periorbital region, and you don't want to do all the work from above through the with the endoscope and through the forehead, it works. And I love that operation. And I modified that from Rod Hester and Mark Codner at RIP. They were doing a version of that, but I found that if you really get it, if you cut through the orbicularis, you use some 5.0 PDS or whatever, and then tack it to the temporalis fascia, you can undermine right through that canthotomy. It's 5 millimeter incision. Beautiful. It really works great. And it's so effective and so safe, and it is the treatment for the problems of lower lid blepharoplasty.
Of the lower lid.
So it takes care of business. It looks great. You want to get them a little more almond-eyed, a little more the fox eye procedure, that's part of it. So I do that also. But those things, I think they just look so nice. And, say goodbye to your concealer.
Yeah, the midface is a very powerful addition to the lower blepharoplasty. And it's really something that you kind of have to look at, not routinely, but pretty commonly when you're looking at the lower lids, with the exception of the young people that just have genetically puffy eyes that just need the isolated fat removed. Usually you're looking at a patient that's starting to see some facial aging changes. And part of that is the descent of the midface, the cheek mass, the muscle, the fat sliding off of the cheekbone and accentuating all of the problems of the lower lid, the grooving, the longer lower lid length. And the lower lid blepharoplasty on its own will correct some of those problems. But if you're really trying to rejuvenate to the most maximum degree, the midface is a very powerful thing to add on because it lifts the lid up, it blends that hollowing that's under the eye, and it just really enhances all the results of the lower blepharoplasty.
And it provides support for the lower lid.
Yeah.
It's a good thing.
And we have we have many mid-face podcasts, so please feel free to look
Yes,
at them.
We like that operation in case anybody didn't pick up on that.
Because it's really good. And so it's not uncommon for someone to come in for a consult just for blepharoplasty. Oh, I just want to have my lower eyelids done. And I say, yes, we can do this, but what you really need is also a mid-face to address this. And then they kind of like lose their minds a little bit because like, I just came in for my lower eyelids. And it's like, that's fine, but if you really want a good result, it'd be really nice to add this on.
Yeah, I mean, look at that one gal from Germany that, came for her breasts, listened to our podcast and was like, I had just my upper lids done and now my brow is down. I look mean. And that's the thing. If you're going to do an upper lid, you really kind of need to do a brow with it. If you're going to do a lower lid, you probably need a cheek lift with it.
Or, as we talked about, I think, on one of our recent podcasts, fat grafting. So if you don't want to do the mid-face and resuspend the cheek mask up into a higher position. And another thing you can do is fat grafting to, again, sort of support the structures of the lower lid, get an appearance of volume, rejuvenation of the cheeks. Now, this is not fat grafting of the eyelid. That I would not recommend.
No.
Don't start sticking fat, in the actual lower lid itself, but putting
is that a mistake?
That's huge. The skin of the lower eyelid is so thin. You really need to respect it, and you can't start futzing around and putting things under it. But a little fat grafting around the lower eyelid is very helpful.
I want to tell you about something I did recently on a facelift. She had been totally hollowed out in her upper lids, and I did a little bit of upper lid sort of frontal bone fat grafting to correct it. Looked really good.
I bet it did.
Very, very judicious, 0.5 cc's, 0.7 cc's, like not a lot, but it really helped because it was so hollowed out. Somebody like just cored that stuff out of there, and it was like...
Do you put it in what space did you put it in?
I put it along the bone, along the frontal bone, basically, the orbital rim.
Yeah.
And went there. I didn't go into the lid because I know that it would go basically where the fat would be up against the the frontal bone there, and it looked great.
It's great. Word of caution to the young surgeons: be very careful doing things like that.
That's a senior move.
You
need some of these. You need some grays.
Yeah, there's some very important anatomy, some very important blood vessels that live in that area.
Get a few grays before you do that one.
Yeah, just know your anatomy and just be careful with that move. Not to say it can't be done. It looks great, but you want to go to someone that really knows where they are and what they're doing with that.
Yeah, that's a Steve Cohen move, and he and I have talked about it. So I was like, she really needs this, and she was like, "Can you put some up here?" I was like, "Let me see." And then I was there, and I was like, I think I can do this. And then I passed the cannula, and I was like, this is going to look really good. And so it turned out great. Looks good. I don't know how much of it will stay. I didn't put a ton. It's something, though, that I would be comfortable putting more in the future. But you don't need a lot to make it look nice. If there's fat there, it needs to be there. Yeah. Fat grafting along the lower of the lower lid is really done into the cheek, basically at the level or below the orbital rim, and it does make a really nice difference. Yeah, no, that is a great option, especially if you're not doing any kind of mid-face lifting at the same time. What do you do for patients that have crepey or extra skin of the lower eyelid? Like, say you do your blepharoplasty, you do your mid-face, and there's just kind of like some bunchy, crunchy skin that's still there under the lower eyelids. So this is where you have several options. The skin pinch is key. We know that by taking too much skin out of the lower eyelid, you get ectropion or scleral show. So you can take some out, especially if sometimes you need it. Yeah, of course. But one of the things that I do, if the skin really is crepey and awful like that, is I'll just lift up the skin, undermine it. Maybe I'll take a few 4 or 5 millimeters out of the lower lid, maybe. But just by picking it up and redraping it, you get a nice sort of reorganization of the dermal structure, and there's less wrinkles. It looks nicer. Well, you create an injury, which creates collagen and creates tightening and scar. And it works. And so this is an incision that goes directly under the lower eyelids, right up against the lower lashes. And the classic skin pinch technique is you just take your forceps and you go all along the edge, and you just take the skin that comes that's a little bit extra when you pinch your forceps together. And when you pinch your forceps together, it creates a little ripple of skin that stands up on its own.
bone, and then you just take your scissors and you trim that skin. I mean, we're talking millimeters here.
Yeah, it's like 3-4 millimeters at the most.
But it does a great, sometimes, especially older patients, they really need that extra skin removed. If what you have is not so much extra skin as just really crepey skin, that's usually best addressed after the fact, or even at the time of the surgery with a chemical peel, a CO2 laser, some kind of Morpheus under the eyes, something that addresses the superficial aspect of the skin to tighten it and smooth out those wrinkles.
Yeah, I love that stuff. It really does make it look better.
Yeah, that definitely brightens, smooths, sort of puts the icing on that cake.
Yeah, I like, for lower lids, I'm pretty careful with the lasers. I tend to use erbium pixel as opposed to CO2.
CO2.
Yeah, I mean, CO2's great, but it's pretty rough.
You have to go to someone who really knows how to use a CO2 laser because the complications there can be very
you can
real.
get an ectropion. You can get problems. I've, by the way, seen it. So, in the repair of an ectropion.
Let's talk about that. Let's talk about the complications of lower blepharoplasty because that's kind of how we started out. Like, why is it so scary? Like, what could go wrong?
So many things. Evidently, which I didn't think of, you can go straight through the whole lid, as you said was demonstrated by
skin.
That shouldn't happen. But I think ectropion and entropion. Entropion's when the lid curls in and the lashes go against the globe, and it's very annoying. Ectropion, the lid goes out and it's pulls away from the globe. Treatment of those depends on how bad it is.
Yeah. And this is where you really, need an eye specialist once you get to this stage, because this is pretty.
Yeah, you do. I mean, I fix ectropions. I feel very comfortable. I love doing canthotomies. I've always been comfortable with them. I did one day on a patient that had scleral shell, bad blepharoplasty, and needed her cheeks reduced with a pineapple burr, like all this. And Jose looked at me and he was like, "Doc, I ain't never seen you do this before." Kind of like one of those deals. And I was like, "Yeah, well, this is something I do. I do this." And it turned out so beautiful. It really saved the day. It fixed the ectropion. You can do all that. You just have to have command of that anatomy. And, we do this a lot. And maybe that's why I was ranked on the blepharoplasty rank list this year in Newsweek, which, I think our blepharoplasties are great. I think it's warranted to, the way that we teach this to the fellows and the residents, they feel really, really comfortable with controlling the lid.
It's very safe because, yes, the problems that we're just talking about are very challenging to fix.
And this technique addresses them.
So ideally, you would not even have the complications. Other things that can happen after the lower blepharoplasty, most of it is transient. You may have swelling, some blurry vision for a little while as things are swollen. You
do get blurry vision from the transconj approach because the interstitial fluid does weep through the transconjunctival incision for a week or two sometimes.
Yeah.
And it's a little annoying.
It's just puffy. And depending on how much work you did on the lower lids and the fat, they can be swollen for quite some time. This area does not drain well. So sometimes doing little facial lymphatic massages is really helpful. Get one of the jade rollers or something and just, start massaging that extra fluid out. And that's helpful because this area just doesn't drain well, so it needs a little help sometimes.
You had the transconj bleph. Did you have that fluid weep issue? Do you remember?
Not that I remember.
Wasn't an issue. Mm-mm. I don't remember you saying anything about that.
I couldn't wear my contacts, so that's another thing.
Right, you can't put your contacts in because you have the incision on the inside of the lid.
It's really swollen. It's uncomfortable. So.
How long before you got contacts?
I think I waited
2 weeks, 3 weeks.
Yeah, a couple weeks. I remember feeling really nerdy and bummed out for a couple weeks. I hate wearing glasses.
You don't feel like that all the time? You served it up. It was the softball. I had to hit it. I'm sorry.
Where is that award?
Listen, I just want to say that, I want to go on record that Dr. Millicent Rovelo is a saint. And she sits in here and she takes my mid-facelift comments and the abuse and she's a trooper.
Yes.
So I appreciate you.
Well, you're welcome. If
you can throw it right back anytime. And I know you do. You do most of the time. Sometimes you just wax me on the back of the head because I deserve it.
Yes, that happens too. But I think, it's just a final, thought on the lower lids. Yeah, just my own personal experience. I had that exact same thing. I had the lower lid, transconjunctival approach, mid-face. And yeah, like I say all the time, I have not worn under eye concealer since then. No hollowing, no grooving, no
But it
step
took you a little
offs.
time to heal it though too, and you did
It
have
did.
like some
There's some muscle weakness,
muscle stuff that was there. It's not a nothing.
No, it's like a real surgery. It's like there's a real recovery to it. But then once you're done, it's like, oh, great. So that's
Healed.
done. Yeah, next.
I need that so badly. God. I'll wait a few months until you're not angry with me for these comments, and then you can do my lower lids. How about that?
How about that? You seem to be on your best behavior for the next few months.
Like January or so, February. Be good then. All right, good.
Yes.
It's time. I really need to do these lower lids. And you did a great job on your patient last week. Like it's time. Just got to get these out. We should do that as a live podcast. That'd be something. My blepharoplasty, you'd be like, no.
No.
It's funny too. Like, I always Terry DeBro is a friend of mine. And he does botched, and we were talking about like what's it like having the cameras in there when you're doing it. He's like, nobody even watches the surgery anymore. He's like, he just kind of said like the surgical part. Nobody needs to see. They want to see the before and the after.
Right.
The audience doesn't know what they're looking at. They don't know what a transconjunctival blepharoplasty is even supposed to look like. It's like so hard to envision. He just said, it just isn't. It's not part of botched. It's really they want to know the plan. Right.
Yeah.
They want to know the story. They want to know what's the plan to fix it. They want to know. So it's interesting to talk to him about that because he's kind of realized that I'm going to do the surgery. It's great. You can have the cameras in there all day long. Nobody knows what they're looking at. It just doesn't make a difference. And it's probably a waste of everyone's time for me to sit there and talk about things that are so out of context. It just does. It'd be like showing me an F-18, fighter jet engine. We don't know what we're looking at.
No clue.
No clue. No idea what we're looking at. You could tell me, well, this is arranged this way. I'd be like,
yeah. But how fast does it go?
I just want to see it fly.
That's the most important.
Yeah, totally. Well, this is good. I think lower lid blepharoplasty is not to be underestimated. It's a really tough operation, but it's very effective. It's awesome, and when done properly, the results are spectacular.
Yep, I agree.
Safety first, know your plan, and I think you too can have amazing results. Does that help?
Yeah.
Anything else?
That's good. No, that's it.
Then this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.